Hello everyone, we are going to talk today about acute kidney injury. In the following lecture, we'll study first the staging of AKI, then we'll study the causes of AKI, the pre-renal, the renal, and the post-renal causes. Then we'll study the specific investigations, clinical features, and the treatment. So this is going to be the overview of the lecture. We'll keep the lecture crisp and concise, starting with the KDO classification, which is mentioned in the picture as well. It is divided into three stages. Stage one is when the creatinine level is between 1.5 to 1.9 and the urine output is less than zero point 0.5 ml per kg per hour for 6 hours. Then the stage 2 comes when the create level goes to 2.9 and the urine output goes less than zero point 0.5 for more than 12 hours. And finally the stage 3, which is when the creatinine level is greater than 3 times, or the overall creatinine is greater than 4 mg per kg, or the person is on renal replacement therapy and the urine output is less than 0.3 ml per kg per hour for more than 24 hours. So this was all about the stages. You need to memorize it. It's really simple. Let's come to the causes. Causes are the pre-renal causes, renal causes, and the post-renal causes. In the pre-renal causes, it can be further classified into either the kidney is getting less perfused blood or some drugs are causing the perfusion to be decreased. First, let's clear the drug thing. In drugs, there are two drugs. Remember NSAIDs and the angiotensin receptor inhibitors, ACE inhibitors. NSAIDs inhibit the prostaglandin secretion, so the vasodilatory effect of the PGs is gone. Kidney receive less blood. Whereas the ACE enzyme, angiotensin enzyme, used to act on the efferent arteriole and it used to cause its vasoconstriction, but ACE inhibitors inhibit it, so ultimately reducing the perfusion to the kidney. Now coming to the second subgroup of prerenal causes in which organ perfusion is decreased. It can be due to some fluid loss occurring through diarrhea, burns, or any trauma. And now coming to some cardiac causes like cardiomyopathies and the cardiorenal syndrome and decrease the perfusion. And finally, the liver diseases as they release nitric oxide and they cause decrease in the systemic vascular resistance. So they cause decrease perfusion. These were the prerenal causes. Coming to the renal causes. Renal causes have been classified into glomerular causes, interstitial causes, and the vascular causes. In glomerular causes, we have acute glomerulonephritis. In interstitial causes, we have further classified into it may be due to sepsis, ischemia, or nephrotoxins. And now these nephrotoxins can be endotoxins or exotoxins. In endotoxins, it can be due to rhabdomyolysis, due to tumor lysis syndrome, or mismatched blood transfusion. Whereas in exotoxin, it can be nephrotoxic drugs like aminoglycosides, cisplatin, or some chemicals like ethylene glycol, or contrast-induced nephropathy. Coming finally to the last, which is the vascular causes. In vascular causes, we can have the hemolytic uremic syndrome, we can have thrombotic thrombocytopenic purpura, we can have malignant hypertension, atherosclerotic kidney disease, renal vein thrombosis. These are the vascular causes. And finally coming to the post-renal causes, in which we have bladder outlet obstruction, benign prostatic hyperplasia, ureteric fibrosis, and scleroderma. All these obstructive causes. Now coming to the clinical features. In clinical features, we have the basic complaints like nausea, vomiting, hiccups, and encephalopathy can be there due to the raised hypertension. Oliguria is commonly found in the patient, and uremic pericarditis also is found in many patients. Now coming to the workup investigation, you will find low sodium levels because due to the increased volume expansion, you will find elevated potassium level. Uric acid levels can be increased. Metabolic acidosis is a finding with a high anion gap is seen and it's treated with sodium bicarbonate. You can carry out the USG to rule out post-renal causes, and there is one test known as FINA test, fractionated excreted sodium. And if FINA test shows it's less than 1%, then it means it's a pre-renal cause, and if it's greater than 1%, then ischemic cause means the tubules are not working and the sodium is more excreted in the urine. Now coming to the treatment. In treatment we do fluid management. Usually we use normal saline if there is a hypochloremia, and if the chlorine levels are normal we give ringer lactate. Furosemide can be used. For metabolic acidosis, as mentioned earlier, sodium bicarbonate is used. For hyperkalemia, dietary restrictions and insulin and salbutamol is used. For hyperphosphatemia, phosphate binders are used. For hypertension crisis, we use labetalol, and for bleeding, we use desmopressin. And finally, if these things are not working, we go for intermittent hemodialysis with double catheter system, or we can go for continuous veno-venous hemodialysis. So this was all about the treatment, and this concludes the topic of acute kidney injury.